We are going to discuss on the core concepts of hyponatremia in this particular section. So this section is essentially a carryover from the previous basics on sodium and water balance. So if you have not yet watched that video, please go back and watch the video and come back here. So hyponatremia will be due to two most important pathophysiological reasons. One might be due to decline in the total body sodium, but hyponatremia due to pure decline in the total body sodium is generally very, very rare. So it's not that common. Second reason, it can be due to excessive total body water. So this excessive total body water that is diluting the total body sodium causing hyponatremia is what we refer to as dilutional forms of hyponatremia. So this dilutional form of hyponatremia is going to be the most important and the usual reason for developing a hyponatremia. And again, this excess water causing dilution can be due to two reasons. One may be due to reduced water excretion, and second may be due to increased water intake. And once again, hyponatremia developing purely due to water intoxication by causing excessive water ingestion is very, very rare. Usually it will be due to reduced water excretion only. That's the usual reason for developing a hyponatremia. So what is going to be the definition of hyponatremia? Hyponatremia is defined as a serum sodium value that is less than 136 milliequivalents per liter, even though some textbooks will give you a value of 135 and less than that. But I, as a clinician, always take this value of less than 136 as the standard, which means you have to know the normal serum sodium value that is in the range of 136 to 144 milliequivalents per liter. So what is the problem in hyponatremia and why we worry about this hyponatremia? Because hyponatremia reduces the tonicity of the ECF and the plasma. When you reduce the tonicity, they can result in fluid shifts. That's why we worry this. Fluid shifts in the sense where to where, from where to where they cause the fluid shift. They are going to cause the fluid shift from ECF towards ICF. Why? Because here the ECF is going to have lower osmolality and lower tonicity compared to the ICF. You know, water always moves from a region of lower osmolality to a region of higher osmolality, that is higher solute concentration. And that's why here the water moves from ECF to ICF. And that is also the reason why the ICF is going to swell up and the cells are going to swell up. And you know, the one important organ that cannot take up this swelling of the ICF is the brain, and you're going to result in a condition called cerebral edema. And that is the reason why sodium changes and especially hyponatremia are associated with neurological complications most of the times. So now, without wasting much time, let us move on to the classification of hyponatremia. How you are going to classify a hyponatremia. Hyponatremia can be classified into mild hyponatremia, moderate hyponatremia, and severe hyponatremia. According to the values, the mild hyponatremia is often defined as sodium in the range of 130 to 135, and moderate hyponatremia is defined as sodium in the range of 120 to 129, and severe hyponatremia anything less than 120 milliequivalents per liter. So you also have to know, it's worthwhile to know that the actual values, that is the serum sodium values in hyponatremia patient, only loosely correlates with the clinical severity, which means the association with clinical severity and the serum sodium values are very, very loose, and they are usually not associated with that much clinical severity. So what is going to predict the clinical severity means I can write that there is one thing that will predict the clinical severity more accurately than the actual value is the rapidity of development of hyponatremia, which means if the patient is having acute hyponatremias, the severity is going to be a bit high, or if the patient is having a chronic hyponatremia, the severity can be much lesser. Why is it so? Because we have already studied this principle, whereas in a chronic hyponatremia, the neurons and the cells in the body would have gone for adaptation. So they know they have to adapt, and they're going to lose some osmoles in the form of in the form of potassium, because potassium is one of the important intracellular osmolate. So they will lose potassium from inside the cell, and they might lose other organic osmolates like taurine, glutamate, glutamine, or myoinositol. So they lose some of these substances, and they may become, like somewhat similar to that of the external milieu. In this case, they will also try to lower the serum osmolality, lower the intracellular osmolality so that they can match with the serum osmolality and extracellular osmolality so that no more water shift happens. So that's how the cell is going to adapt. So because of the cellular adaptation in a chronic hyponatremia, you might have very subtle symptoms or no symptoms at all. So if they ask you what could be the symptoms of chronic hyponatremia, could be anything basically, depending on the severity, but often they tend to have subtle symptoms. What are the subtle neurological symptoms? But often they have very subtle neurological symptoms like recurrent falls. That may be due to postural instability or a gait instability. Very, very important in chronic hyponatremia, especially in elderly patients. They can come with gait instability, recurrent falls, or they can even come with behavioral changes, mild behavioral changes, not like typical altered sensorium agitation. They might have mild behavioral changes and personality changes, which might mimic some forms of dementia also sometimes. So this is the reason why you have to know that the rapidity of development of hyponatremia is the one that's going to predict the exact clinical severity. So let me tell you mild hyponatremia and what will be the symptoms. Usually they tend to be completely asymptomatic. Even if they are symptomatic, the symptoms are going to be extremely mild, like they'll be feeling lethargic and they might be feeling anorexic and they might have some muscle cramps. That's all. So if you move on to the moderate hyponatremia, again, I would like to substantiate the fact that moderate hyponatremia means you have to develop all these symptoms. They can be completely asymptomatic as well, again, depending on the rapidity. So that is what is more important rather than the exact value of sodium. So moderate, they will start developing symptoms of rising ICP like headache, intractable nausea and vomiting, and they can develop altered mental status. So in the form of disorientation, agitation, all these things. Again, I'm warning you, the clinical severity may not correlate with the exact sodium value. So you might get the patient to be completely asymptomatic as well if the development of hyponatremia is very chronic. So be very careful. This is also a real-time possibility. So if the patient is having severe hyponatremia less than 120, it's likely that the patient will be symptomatic than asymptomatic. It's unlikely to be asymptomatic with the serum sodium of less than 120. But what symptoms they develop is the question. And again, they could develop only mild to moderate symptoms if the adaptation is very good and it's a chronic hyponatremia, but it's an acute hyponatremia means they can develop symptoms like coma, seizures, areflexia, and altered breathing patterns like Cheyne-Stokes respiration. All these things are possible and can possibly happen in a patient with a sodium value of less than 120. But this is not a must again. Again, I'm warning you one final time that the clinical severity is usually dependent on the rapidity of development of hyponatremia rather than the exact value of the plasma sodium, which loosely only correlates with the clinical severity. Okay, now after knowing about the symptoms and the classification of hyponatremia, we will move on to how will you understand the etiologies. So how to classify the hyponatremia based on etiology and how will you have an approach to hyponatremia. So approach wise, whenever you encounter a patient with a low serum sodium hyponatremia, you have to see the serum osmolality next. So this serum osmolality is nothing but a measured serum osmolality by a machine, not a calculated serum osmolality. So see the measured serum osmolality that is given by your lab. It can be having a normal serum osmolality or a low serum osmolality or even a higher serum osmolality. Remember, if it's a true hyponatremia, it's unlikely to have a normal or a higher serum osmolality. If it's true hyponatremia, the serum osmolality will be definitely low. So that is why these patients with normal or higher serum osmolality in a patient with hyponatremia, we tend to call it as a false hyponatremia. So what are the types of false hyponatremia? We have something called a pseudo hyponatremia, because here the osmolality is normal, and you can get a hyperosmolar hyponatremia. That is also definitely a false hyponatremia only. If the serum sodium values, serum osmolality values are low in the presence of hyponatremia, then it indicates a true hyponatremia, or simply we can even call it as a hypoosmolar type of hyponatremia, which is a true hyponatremia. So why you get a pseudo hyponatremia? That too, patient is having a normal serum osmolality. Why is that so? For that, you have to understand how they measure the sodium, the lab values. So let us assume these are the cells that are having in a blood sample, and the plasma is nothing but centrifuged, like coagulated, uncoagulated blood. It's a whole blood that is centrifuged, and what you obtain is what we call as the plasma. When you make the blood to clot and then you centrifuge, and what you obtain, the supernatant, is what we call the serum. So this is the basic difference between serum and the plasma. So they are usually going to measure in the plasma only rather than the serum, most of the machines. So how they measure is by calculating the sodium and the plasma volume, and you are actually taking a ratio with the plasma value. So let me tell you, this area of the plasma volume is made of protein and fat. So how much plasma volume is made of protein and fat? Is it 7% usually? This is the usual number that is contributed by the proteins and the fat in the plasma. Remaining 93% is actually contributed by the plasma water. So this plasma water is going to contribute to 93% of the plasma volume. So these are the cells that form the hematocrit that we are not going to discuss now. So now if you take, this is the total plasma volume. So which is a combination of both plasma water as well as the protein and the fat component of the plasma. So how the lab measures the sodium, how the machines measure the sodium, is by the fact they take up the sodium in the entire solution and they're going to divide it by plasma volume. But ideally speaking, it should not be done because the sodium is actually dissolved in the plasma water only. It's not present in the protein or the fat. So spuriously, if something that elevates the plasma volume but not water, it might result in a spuriously low sodium. How? Suppose let us take a second example where the patient is having same amount of cells. I'm not changing the amount of cells, but actually let me change the amount of protein and the fat. So let us assume this is the amount of protein or fat which is increasing, and this is the remaining plasma water. But you can see here the plasma water has not changed much in absolute amounts, but there is a lot of increase in the proteins and fats, proteins or fats, anyone. So that has made the plasma volume to increase. Plasma volume has increased dramatically here. But if you take the same formula, that is the net sodium in the solution, which is actually normal, there's no change in the water, and there's no change in the sodium dissolved in the water as well, that's normal. But if you take the plasma volume, which has increased, obviously the serum sodium values will be low, that is shown by the machine only. So this is what we call it as a pseudo hyponatremia. So what will be the causes of pseudo hyponatremia? The cause of pseudo hyponatremia will be, number one, whenever there is excessive fats. In the sense, whenever you have a very, very high triglyceride, or when you have a very, very high cholesterol levels. Very high cholesterol levels, or you have something called a lipoprotein X, which I'll tell you in some time. So very high triglyceride levels you might encounter in patients with hyperchylomicronemia. Hyperchylomicronemia, where triglyceride levels often exceed 2000. In hyperchylomicronemia patients, usually the blood itself will look lipemic, especially the blood might itself look like as if you are taking a fat out of the body rather than the red colored blood. So it may be look lipemic, but this excessive cholesterol related blood and excessive lipoprotein X related blood, in this condition, the blood will not be lipemic. It will not have a lipemic appearance. As I told you, the hypertriglyceridemia is usually due to hyperchylomicronemia, that is type 1, primary cholesterol disorder, primary lipid disorder. But whereas this condition with excessive cholesterol and excessive lipoprotein X usually happens in cholestatic conditions, cholestatic states. And I can also tell a very interesting association that every 886 milligrams per deciliter increase in the triglycerides, there will be 1 milliequivalents per liter fall in the serum sodium, spuriously. This is an interesting association. Similarly, you can get with excessive proteins as well. So there are too much proteins that contributing to the plasma volume. This can happen in a simple disorder like multiple myeloma, where there is too much of immunoglobulin circulating so that they might raise the entire plasma volume. So, and again 1 gram per deciliter rise in the proteins will result in simultaneous fall of serum sodium by 0.7 milliequivalents per liter, again spuriously. It's not a true hyponatremia. So how can you avoid? The problem is the mission, like not counting properly. So we have some machines like direct potentiometry. So this can tell you the exact amount of sodium in the sample, and this will avoid bias by this condition that produces pseudohyponatremia. So use this direct potentiometry if you are in doubt. But final take-home point, what are the causes of pseudohyponatremia? Hyperchylomicronemia, cholestatic jaundice or any conditions in the liver causing cholestasis, and multiple myeloma. So these are 3 standard conditions that you have to at least know for the exams. Next, where will you get a hyperosmolar hyponatremia? Now let us assume there is an osmolar substance that is circulating in the intravascular compartment. This could be anything. A lot of osmolar substances are there that can circulate in the intravascular compartment. So this osmolar substance is incapable of moving into the ICF. That is the reason why they start exerting their osmolar forces from the intravascular compartment or from the ECF, and they're going to cause water shift out of the ICF into the ECF. This water movement out of the ICF into the ECF caused by this osmolar substance is going to result in a transient expansion of the intravascular volume. And again note this word, transient expansion of intravascular volume. And it's going to create a dilutional effect. Because of this dilutional effect, they will result in a condition that is spuriously causing a hyponatremia. How? Because when you take this column of blood, and if the machine examines this column of blood, it's going to see there is excessive water in this area compared to that of the sodium, and they will give a hyponatremic value only. They'll have a low sodium. They'll give as if they're having low sodium. That is because of the transient water that is present in the intravascular area, intravascular compartment, that is caused by the presence of solute, hyperosmolar solute. And this solute is the one that is raising the calculated serum osmolality that are calculating in the machine. And why I'm using the word transient all this while is because this solute is not going to stay within the intravascular compartment. They're going to get excreted, and they're not only going to get excreted, they're going to take water along with them. And this principle is what we refer to as something called a solute diuresis. And they are going to pull a lot of water out of the system along with them. So if you take the real equation, it's the total body sodium by total body water. Here the total body water is lost dramatically because of solute diuresis, which should actually increase the serum sodium by equation, which means the patient should be in hypernatremia, not hyponatremia, but what the machine is actually showing is hyponatremia. It shows correctly only because it shows what it sees. It doesn't know what's exactly happening in the body. That hyponatremia that is false or spurious is because of the transient expansion of the intravascular volume by water and resultant transient dilution of the intravascular compartment by this water that is retained by the solute in the intravascular compartment. So what are the things that can cause this hyperosmolar hyponatremia? Obviously, it's glucose, the first thing. Severe hyperglycemia can cause, especially when you have a decay or a hyperosmolar hyperglycemic state previously called as HONC. Or if the patient is having high urea in the blood, like if the patient is being given high protein diet in the enteral feeding. So when you give directly enteral feeding with high protein content, the bacteria can break down this protein into urea. So that's the reason. And urea is a very good solute as far as the kidney is concerned. So they can result in solute diuresis. Then it might happen when you give some iatrogenic hyperosmolar agent like mannitol. Alright. Then it can also happen after procedures like TURP, transurethral resection of prostate, or after procedures like hysteroscopy, where they can use irrigation solutions or hyperosmolar irrigation solutions like glycine or sorbitol. Remember, this glycine or sorbitol are hyperosmolar substances, and once they get absorbed into the systemic circulation, they're also going to produce similar effect like that of a mannitol. Like they are going to cause a spurious and false hyponatremia. Okay. Let us take a best case scenario example where there is excessive glucose in the blood and the serum. So why you have a lot of glucose in the ECF? Because you don't have insulin in that patient. Because of low insulin, glucose cannot be pushed into the ECF, so they stay in the push in the ICF. They stay in the ECF, and they're going to exert their osmolar effect in the ECF. So this excessive glucose, obviously they will exert their osmolar effect, and they're going to increase the serum osmolality, and this will result in fluid movement from ICF to ECF. Water movement from ICF to ECF. And this will obviously result in transient dilution of the ECF, and the patient will be having hyponatremia. The serum sodium levels will be low. And you can actually predict how much the serum sodium will reduce, especially when the patient is having hyperglycemia. Math tells that whenever the glucose increases by 100 milligrams per deciliter over the value of normal value, that is 100, there will be simultaneous decline in the serum sodium of approximately 1.6 to 2.4 milliequivalents per liter. So even though the values are variable, but standard textbooks give a value of 1.6. So you can, in the exam, you can take every 100 milligrams per deciliter rise in the glucose over a normal value of 100. So you are going to have a decline that's a spurious decline in the serum sodium of approximately 1.6 milliequivalents per liter. So which means, suppose if my blood glucose is 600 and if my serum sodium is only 128, so this is the blood glucose and this is the serum sodium, I can correct this serum sodium value because my actual serum sodium will be something else. I can actually correct the serum sodium value by knowing that calculation. You know what, every 100 increase after 100, 1.6 is going to reduce. That is spurious effect. So which means for every 100 increase, you have to actually increase 1.6 from the normal value. So here, after 100, 500 is increasing. For every 100, 1.6 is increasing. So 5 into 1.6. So you are going to have 8 milliequivalents rise. That is the actual sodium range. So which means the corrected sodium will be 136 milliequivalents per liter. So this will be the corrected sodium. So, or if you want to express in mathematical range, how can you express mathematically? So corrected sodium will be equivalent to 1.6 multiplied by actual serum glucose minus 100 divided by 100. So this will be the corrected serum sodium. So if you use this formula, you will get the corrected serum sodium, and you can actually know what is the actual level of sodium going on in the body. So, and if you want to have one more understanding, so I told you again, in DKA and HHS, the patient will have very high glucose, and initially they'll have a false hyponatremia because of that, hyperosmolar hyponatremia. So why you are getting this hyperosmolar hyponatremia, this false hyponatremia? That is because of the solute, that excessive osmolar substance that is present in the blood. So now let us assume this osmolar substance is no longer present in the blood, which means you have removed all this osmolar substance. In this condition, you have normalized the serum glucose. By giving insulin or doing some thing, you have normalized the serum glucose. Now this glucose will no longer exert osmotic effect, and they can no longer pull the water back into the intravascular compartment, and they no longer can cause the transient dilution and transient hyponatremia. And now once the glucose is normalized, the hypernatremia starts surfacing, which means the hyperosmolarity and its true face will start surfacing in the patient. So that is the reason in these patients, initially whenever you have a very high glucose, you treat with normal saline. Why? Because they would have caused a lot of solute diuresis. In the presence of hyperglycemia, the patient would have been in shock and severe dehydration because of the solute diuresis. That much solute diuresis they will cause. But once you have corrected the glucose, and you have corrected the shock and dehydration, that is especially when the CBG becomes less than 250, you have to immediately shift your fluid to hypoosmolar solutions like half normal saline or dextrose 5 water with insulin, or 5% dextrose with insulin. Both are the same. So this is what you are going to do. So, and this is the principle, because once the glucose has normalized, the patient will start going towards hypernatremia if you don't correct the water deficit that the patient is having. So you have to correct the water deficit by giving hypoosmolar solutions like dextrose 5 water or half normal saline. So be very careful. So this is the basis of these guidelines, which we'll be studying in the diabetic section. So this is easy to find out because the patient will be having hyperglycemia, severe hyperglycemia, so that's easy to find out. So urea, again, the patient will be on enteral feeding and you have a good history for that. And mannitol, it's hydrogenic and you'll have a good history. And even TRP and hysteroscopy, with a good history you can find out, but during a TRP or hysteroscopy, you don't know whether the patient is having truly hyponatremia because of hyperosmolarity of the substances that are getting absorbed, or it's some other reason like SAIDH after surgery, because post-surgical SAIDH is also very common. So that is causing hyponatremia. So how will you find out? To understand this, you have to know an entity called osmolar gap. So what do you mean by osmolar gap? It is a difference between measured serum osmolality and calculated serum osmolality. So what does this matter? Let us see. So what do you mean by measured serum osmolality? This is given by the machine. So what are machine you are using to test the osmolality? And what do you mean by calculated serum osmolality? Calculated serum osmolality is something where you do by your own ways of calculation. Like, you know, how will you calculate the serum osmolality? You are going to take 2 into serum sodium plus glucose divided by 18 plus blood urine nitrogen by 2.8. So this is what we refer to as a calculated serum osmolality. So usually if you don't have any extra osmoles in the blood, so measured serum osmolality should be almost equal to the calculated serum osmolality, which means the osmolar gap should be less than 10. That is normal. Suppose if there is some excessive osmol in the blood that you are not taking care, that you are not calculating in your calculation, so then the osmolar gap will become more than 10. Clear? So this osmolar gap of more than 10 clearly indicates there is presence of some excessive osmol in the blood. So which means what I'm trying to tell is you are not only having these 3 compounds, you're also having some X compound. In this case, it's sorbitol or glycine that is circulating in the blood, and you're not calculating that. So that is the reason why there is a gap between the machine osmolality and the calculated osmolality. So that is what we call it as osmolar gap. But if you have taken care of this also, then obviously both should be equal then. But here you're not actually calculating this properly in your equation. That is the reason that is reflecting as a high osmolar gap. So this is one way to find out the circulating sorbitol and glycine causing hyperosmolar hyponatremia. Clear? So this is a very important concept again. So these are the things, first of all, you have to know before going into the true hyponatremia related approach. Here you can see one strange thing. Whenever you have a hyponatremia, the water should move from ECF to ICF. Then only you can call it as a hypoosmolar hyponatremia, right? So this should be the fluid shift. But strange enough, you can see in hyperosmolar hyponatremia, the water is actually shifting from ICF to ECF. This is very, very strange, isn't it? That's why it's actually a false hyponatremia. This type of hyperosmolar hyponatremia is also called as factious hyponatremia, which means in hyperosmolar hyponatremia, there is fluid shift from ICF to ECF rather than from ECF to ICF in case of a true hyponatremia. Similarly, in pseudo-hyponatremia, I told you the serum osmolality is actually normal. How can you cause fluid shift in the presence of a normal serum osmolality or a normal plasma osmolality? So that is why in a pseudo-hyponatremia, there is actually no fluid shift happening. Actually no fluid shift happening. That is the reason the patient will be completely asymptomatic. There is absolutely no problem. No fluid shift is happening at all. It's again a spurious cause, a false cause. But on the other hand, hyperosmolar hyponatremia patients can be extremely dehydrated because of solute diuresis happening in these patients. They can have severe dehydration. You can have a severe dehydration in these patients because of solute diuresis. And the patient can be in severe hypotension and shock state also. You have to take care of that. But now let us move on to the true hyponatremia, that is hypoosmolar hyponatremia. So I'm going to write separately here because of lack of space. So true hyponatremia, which means the patient will have low serum osmolality, otherwise referred to as hypoosmolar hyponatremia. So how will you approach a hypoosmolar hyponatremia? Obviously, the most important thing is to see two things. One is whether the patient is using a thiazide diuretic or the patient is having advanced renal failure. This is the first thing, because this is a clinical approach I'm telling you. So whenever the patient is taking a thiazide, or if the patient is having advanced renal failure, you take that as the cause. That's all. So which means the cause will be either a thiazide induced hyponatremia, or it could be a CKD or an advanced renal failure with very, very, very low GFR. In this condition, water retention will be too much. That's why they produce this hyponatremia. So this is again easily correctable. The treatment will be either stop the thiazide diuretics and treat renal failure. That's all. That's going to be the key. So this is a very, very practical approach. So this is how we are going to work it up. Suppose if the patient is not taking any thiazide diuretic or patient is not having renal failure, which means the patient is having a normal GFR, in this circumstance, see the volume status. Very, very important. Volume status of the patient. Volume may be hypo. The patient's volume status may be hypovolemic. You know what are the examples of hypovolemia? The patient may have sunken eyes, then loss of skin turgor, and patient may have postural hypotension, low JVP, hypotension in fact, overt hypotension may be there, shock may be there. So these are the evidence of hypovolemic state. Or the patient may be euvolemic as well. Euvolemic, obviously, the patient should have normal JVP, no effusions, no edema, no ascites. So you know all these things. So this is euvolemic status. Or patient can be in hypervolemic status, or patients may be exerting signs of volume overload. Clear? So whenever you have signs of volume overload, definitely this patient will be having low effective arterial blood volume. So that is the cause. So renal failure we already discussed. That's why I'm not telling that. So it should be low effective arterial blood volume. Because of that only they're having RAS hyperactivation, and because of that they're having volume overload state. So three conditions you have to know in this. One is cirrhosis, CHF, and nephrotic syndrome. Nephrotic syndrome. These are three classic conditions that you have to know. Remember, cirrhosis and CHF, this hyponatremia itself is going to tell you a poor prognosis. Hyponatremia, if it's present, and again it's due to dilutional, and again it's telling a poor prognosis. How can you put the equation here? In hypervolemic hyponatremia, you know that the patient will have a higher total body sodium, but the problem is they have more total body water than compared to the sodium. That's why this water is producing the dilutional effect in this hypervolemic patient, causing this hyponatremia. Clear? So these are three classic causes. And in all these conditions, remember, even though they are hypervolemic state, their urinary sodium will be low, which is clearly telling that is due to RAS activation causing excessive sodium reabsorption. And because of that excessive sodium reabsorption, they are having excess sodium overload in the body, causing hypervolemia. And because of water also is retaining more compared to the sodium, you are getting hyponatremia. Whereas in renal failure, you will be actually having high urinary sodium. You have to know that. Okay, that's a basic. Now we'll move on to the hypovolemic hyponatremia. In a patient with hypovolemic hyponatremia, that the patient is hypovolemic means you have to see the urinary sodium. So when you see the urinary sodium, you can divide into two, where the patient is having urinary sodium of less than 25 or urinary sodium of more than 40, or somewhere interim urinary sodium of 25 to 40. Whenever urinary sodium is less than 25, it clearly tells you the hypovolemia is not due to urinary sodium loss. But before knowing that, let us put the equation here. What will be the equation? Here the total body sodium will be low and the total body water will be low, and usually this will not match actually. The total body water loss will be much lesser compared to the loss of sodium. That's why they're having hypovolemic hyponatremia. But my question is where you are losing this total body sodium, which means where you are losing this sodium in the body. Suppose if you are losing in the kidney means the urinary sodium must be high. If you are losing in the GIT means the kidneys will try to conserve the sodium, so the urinary sodium must be low. So usually we think about gastrointestinal causes. Typically lower gastrointestinal causes like diarrhea, pancreatic cause. So some reason will be there. Fistula, intracutaneous fistula, something will be there. Usually it's a GIT, lower GI cause. Suppose if the urinary sodium is high, so what could it indicate? It could indicate the patient might be having a renal cause, which means a renal salt wasting cause. Very, very, very important. So what are the conditions that produces this renal salt wasting? Number one, it is always in exam you have to think about primary adrenal insufficiency. Very, very important cause of renal salt wasting because of mineralocorticoid deficiency happening here. They lose the salt. Number two, it can happen in conditions like cerebral salt wasting syndrome. So these are the two things that you have to think about whenever you think about a renal salt wasting. And one more condition that can produce high urinary sodium is vomiting. And many students are very surprised by the fact that why vomiting causes high urinary sodium, and this is a very crucial concept to understand because I'm going to use same principle in acid-base disorders also. So let us see the pathophysiology of vomiting. The most important constituents that a vomitus loses is hydrochloric acid, that is H plus and chloride. This H plus loss is going to result in metabolic alkalosis, and this chloride loss will result in hypochloremia. Clear? So this is what we refer to as something called a hypochloremic metabolic alkalosis. But vomitus doesn't have a decent amount of sodium and potassium because especially the potassium is very important. Hypokalemia is not a feature of acute vomiting at least. Because vomitus has only, the upper GI secretion has only 5 to 10 milliequivalents per liter of potassium, but the richest source of potassium in the intestine is the colon. Colon is the one that's going to maximally secrete potassium in your entire intestine, which means in diarrhea, because of washout of this colonic potassium, you might result in hypokalemia. But vomiting rarely causes hypokalemia. They only produce this hypochloremic metabolic alkalosis. So what are things you are going to get? This metabolic alkalosis, I can write as high serum bicarbonate because low acid is equivalent to high bicarbonate. So high bicarbonate. So this excessive serum bicarbonate means that the patient will have excessive filtered bicarbonate also, because whatever is in the blood only is going to come into the urine. So my filtered bicarbonate will be very, very high, which means I'm going to lose a lot of bicarbonate in the urine. So urinary bicarbonate also will be high. This is what we refer to as bicarbonaturemia. And this will produce an alkaline urine, which means pH will be more than 7, at least in acute vomiting. Now this bicarbonate is not going to go alone. It's going to pull a lot of sodium along with it, and it's going to excrete in the form of soda bicarbonate. So there will be high urinary sodium as well. That's why urinary sodium here is more than 40 in vomiting. This is the main reason. Clear? So that is why whenever you have an acute vomiting, I can write what will be the pH of the urine, and what will be the sodium in the urine, and what will be the chloride in the urine, and what will be the bicarbonate in the urine. So, chloride is obviously going to be reduced. That is because serum chloride is very, very low. Because you have a very low serum chloride, chloride will be very low in the urine as well. That is because the filtered chloride also will be very low. Clear? So pH will be increased in the urine, that is more than 7 usually. Sodium will be high, chloride will be low, bicarbonate will be high. This is the thing that is happening in the urine in acute vomiting. But in chronic vomiting, what's going to happen is you are losing sodium in the urine also. You are losing sodium in the vomitus also, decent extent. To an extent, you are losing sodium in the vomitus also. This loss of sodium and chloride also is getting lost. Net chloride is also lost in the vomitus. Like chloride is not lost in the urine, but it's still lost in the vomitus. So this sodium and chloride loss will result in hypovolemia. And this hypovolemia is going to trigger RAS. Aldosterone. Aldosterone's primary function, there are 4 important functions. One is to cause increased reabsorption of sodium. Second is to cause increased reabsorption of bicarbonate. By virtue of its sodium reabsorption in the collecting duct, obviously the potassium has to go out. We saw this principle already, and we'll discuss in detail in the subsequent sections. And at the same time, they also have to excrete H plus along with potassium. So this is the principal effect of aldosterone: increased sodium reabsorption, increased H plus and K plus secretion, and increased bicarbonate production and reabsorption. That's why in hyperaldosteronism, you get sodium overload and hypertension, hypokalemia, and metabolic alkalosis, not acidosis. So that is because of excessive bicarbonate getting reabsorbed, and at the same time you are producing excessive H plus that is in the urine. So what will be the effects of whenever the RAS system gets activated? The effects will be completely different. The urinary sodium will start decreasing. At the same time, your urinary potassium will start increasing, and your urinary bicarbonate will start decreasing again, and urinary H plus will start increasing again. Which means what you are seeing is, you are seeing actually an acidic urine. And this is something like a paradox. Why? Because this patient is having excessive bicarbonate in the blood. And whenever you have an excessive bicarbonate in the blood, you should have excessive bicarbonate in the urine as well. That's normal physiology. So if I drink more water, I have to pee more water. If I have more water in my body, I should pee more water. If I have more sodium in my body, I should leak out more sodium in the urine. If I have more acid in the body, my urine should have more acid. If I have more alkali in the body, my urine should have more alkali. But in this patient, in late stage of vomiting, the blood is having more alkali, but actually I'm peeing more acid, which is like a paradox. That's why it's called a paradoxical aciduria. Very crucial concept once again. So I can write the urinary constituents in late vomiting, that is after 3 days usually, where the pH will be low. Actually it will be less than 5.5. They become acidic, and urinary sodium will decline. Urinary bicarbonate also will decline, but urinary chloride will still be low. So why? Because there is low chloride, and the patient is persistently losing chloride through vomiting, and the serum chloride will be low and urinary chloride will be low, no matter what. They cannot produce, like chloride, and they will start absorbing more chloride also. That's the reason. So urinary chloride will be low. So which means the only thing that is persistent in acute as well as late stage of vomiting is the low urinary chloride. That's why this is a very important, reliable finding in vomiting patients. Low urinary chloride. Diarrhea will have low urinary chloride. That is because of low sodium in the urine. So leave that. But definitely, these patients will have low urinary chloride only. Fine. So that's how you differentiate between the condition that produces renal salt wasting and vomiting. Number 3, one more condition I can tell in renal salt wasting, that is acute usage of diuretics. Again, why I'm using acute diuretics? Because they only transiently cause hypovolemia. But usually chronic usage of diuretics will result in euvolemic state only. They will not result in hypovolemic state. That is because of equilibrium they achieve, which I have again described in the last video itself. So please be very careful. Acute diuretic use or overdose of diuretics in the acute setting, you might result in hypovolemic hyponatremia. That will be only transient. Okay. So how can I differentiate? I told you in renal salt wasting there will be high urinary sodium along with high urinary chloride. Whereas in vomiting there will be high urinary sodium but there will be low urinary chloride. Very, very important. Vomiting means low urinary chloride, that's all. That's it. Low urinary chloride. That's all. So this is the pathophysiology of vomiting that you have to understand. Suppose if the serum sodium, urine sodium is in the range of 25 to 40. So this is actually an indeterminate range. That's why you should do something and repeat the testing. Here it could reflect the dietary sodium, which means, sometimes the dietary sodium may be low and dietary sodium may be high. And if the dietary sodium is very, very low, they will still excrete low urinary sodium. Or the dietary sodium is extremely high, they might excrete more amount of sodium despite having hypovolemia, and it might be spurious. That's why in indeterminate cases, you infuse 1 liter of 0.9% NaCl, that is normal saline, and recheck urinary sodium. So this is what you're going to do in a patient who's having a indeterminate urinary sodium in the range of 25 to 40. Clear? Now let us move on to the euvolemic hyponatremia. So in euvolemic hyponatremia, usually the urine osmolality is the one that gives a good analysis of what's the problem happening rather than the urine sodium. Why? If you take the equation of a euvolemic hyponatremia, obviously it's the water increase that is causing the problem here, whereas the total body sodium will be normal. That's why the patient is euvolemic. The total body sodium normal means your intake of sodium must be equal to loss of the sodium. intake must be normal, loss also must be normal, then only the patient can have normal total body sodium, then only patient can have euvolemic. That's the assumption here. Which means here the urinary sodium will be more than 40 only, which actually reflects the intake. Intake is normal, so urinary sodium will be more than 40, which is normal, and that's why urinary sodium will not be a good reflector of what's happening. So see the urine osmolality. Urine osmolality, if it's less than 100 or more than 100. If urinary sodium, I mean both indicate water intoxication only. So whenever urinary osmolality is less than 100 or more than 100, in a euvolemic patient, always it's water intoxication. That's the reason. That's why you get a hyponatremia. But you are finding out what is the reason for water intoxication. If urinary osmolality is less than 100, it is due to excessive water ingestion. That is why the urine is diluted. Suppose urine osmolality is more than 100, which means here you are having excessive water conservation. That is reduced water excretion. You can write like that also. Reduced water excretion. That is the reason why you are having this higher urinary osmolality, more than 100. What are the three classic conditions where you have urine osmolality more than 100 and higher water conservation and lesser water excretion in the urine? One is obviously SAADH. Here there is high ADH, because of that you will get increased water conservation and lesser water excretion, causing high urine osmolality. And second is hypothyroidism. We know by unknown mechanisms that hypothyroidism, especially if severe and mixed edema, causes SAADH-like picture. And hypocortisolism due to secondary adrenal insufficiency. Again, this is a very, very important thing. Clear? So then, these are the three conditions which you have already seen and we already know, we have discussed in the SAADH chapter itself. Now, if you have a low urine osmolality, means it's excessive water ingestion, that's the problem. So there are two reasons where you can get excessive water ingestion. One is relative excessive water ingestion. Second is absolute excessive water ingestion. So what do you mean by relative excessive water ingestion? Relative water excessive ingestion happens in conditions when there is low solute intake. Whenever the patient is having a low solute intake, it's relatively they have a high water intake. Because of that, there will be abnormal mismatch between water and solute, so there will be water intoxication in these patients. There are two conditions which can produce this. One is called a beer potomania, where the patient who's taking beer for a long time chronically, and again they'll be heavily malnourished because they take very little solutes, and relatively there will be more water in their diet. And second is tea and toast syndrome. This is a typical Western syndrome where elderly people who cannot cook their own food will be dependent on this tea and toast, which has a high, like water, relatively high water compared to that of the solutes they are taking. They'll be having very, very low solutes in their diet. So to understand this, it's very easy to know one important principle, that solute should match the water excretion. And the kidneys are trying to work on that only. So let us assume a patient who's taking a normal amount of solute. Normally, how much usually we take is 900 milliosmoles of solute. This is the solute load that we give to the kidney per day, normally, approximately. But I want to excrete this solute in as little water as possible. Suppose if I'm not ingesting any water, to excrete this 900 milliosmoles at a maximum concentration of 1200, which means the urine can concentrate only up to 1200, which means my urine osmolality cannot reach more than 1200. This is the maximum urine osmolality I can reach, because my sodium potassium 2 chloride transporter, the thick casting limb of loop of Henle's capacity is this much only. If you are born as a desert rat, then you can concentrate up to 5000, 6000 also, because they have evolved in those tough situations to excrete more solutes in a very, very small amount of urine, and they conserve a lot of water which is needed for their extreme environment. But for us, it is only 1200. That's the maximum you can reach. So if you want to excrete this normal solute load with the least amount of water, so how much water I need? So it's very simple. It will be the solute load, that is amount of solute, that is 900 milliosmoles divided by volume of the urine, concentration of the urine, that is 1200 milliosmoles per kilogram. That is going to give the volume of the urine. Clear? So once I cross out this, it will be 3 out of 4, and now it will be, I think, 0.75 liters, which means this is the minimum amount of urine that I have to excrete this solute load of 900 milliosmoles. This is the minimum amount of urine I should produce, 750 ml. Suppose if I want to produce in the least concentrated urine, suppose if I'm taking more and more water, how much water I can take so that it doesn't result in water intoxication and I can excrete all the solutes. Let us see. Remember, the least amount of concentration of the urine that they can produce is 60. Humans can produce 60 milliosmoles per kilogram or 60 milliosmoles per liter. So if I want to excrete the same amount of solute, that is 900 milliosmoles per kilogram, and to excrete them safely in the maximum possible amount of urine. Maximum possible amount means I have to excrete at 60 milliosmoles per kilogram. So the urine osmolality must be 60 milliosmoles per liter or 60 milliosmoles per kilogram. And this is where the maximum dilution of the urine can be achieved. So which means if I am excreting this 900 milliosmoles of solutes at 60 milliosmoles per kilogram or 60 milliosmoles per liter of urinary concentration, I'll end up with 15 liters. Which means I can take up to 15 liters of water without causing any water intoxication. Because even if I take 15 liters of water, the kidneys can adapt to it by diluting the urine so much at a concentration of 60 so that I can excrete all the water, whatever I'm taking in excess. But if I take more than 15 liters of water, I will start getting water intoxication and hyponatremia. Why? Because solute, like they can only concentrate up to this least value, which means your maximum dilution has been achieved, and still you have to excrete this much amount of solutes only, means there is a mismatch again. So now more water is there compared to the dilution capacity that is present in the kidney. So which means water will be conserved and you will get intoxicated with water. A normal person who's taking 900 milliosmoles of solute can drink up to 15 liters of water per day without getting any serious water intoxication. But remember what happens in patients who are taking less amount of solutes. Let us assume a patient who's taking only 240 milliosmoles of solute. So how much water can be ingested before getting water intoxication in these patients? Let us see. So when you talk about water intoxication, think about least amount of concentration or maximum dilution that is possible. That is 60, which means it comes only up to 4 liters. Which means a patient who's taking less amount of solute, they can get water intoxication at a very less amount of water itself. Suppose this patient who's taking less amount of solute, just drinking more than 4 liters of water can cause water intoxication, because beyond this they cannot dilute, and that water, whatever you are taking excess, it will be conserved in the body. Similarly, a person, let us assume, who's taking only 120 milliosmoles of solute per day. Here this patient will be extremely malnourished, that's a different idea, but let us assume only this much is taking. So even if he dilutes this urine to least amount as possible, maximum dilution as possible and least concentration as possible, he needs only 2 liters here to excrete these solutes, which means anything more than 2 liters you take in this patient who's taking this low amount of solute will result in water intoxication, because there is no more solutes are there to excrete along with the water. So already all the solutes that they are taking per day is excreted, and whatever water they are taking in excess beyond this is a excess only, they will be conserved in the body. That's the idea. So obviously your water intoxication depends on amount of solutes you are taking also. In low solutes you are taking, relatively you might be taking more and more water compared to what the solutes you are taking, so you might result in a water intoxication as well. So that's why I told you it's a relative cause. Remember, it's not necessary that you have to take more than 15 liters only. With respect to low solute, even if you take more than 2 liters of water, you are actually producing a water intoxication. That's why it's a relative effect. So in these two conditions, where there is low solute intake, you might result in water intoxication easily, because you might easily exceed that 2 liters mark if you are taking very, very less solutes like 120 milliosmoles. Now, what do you mean by absolute water intoxication? Where the patient is actually taking more water psychogenically, irrespective of whether the patient is taking low solute or high solute. Here the patient might be taking normal solute, 900, but he will be taking excess water like 20-30 liters per day. That's what we refer to as a psychogenic or primary polydipsia. We saw all these disorders in the previous video. Psychogenic or primary polydipsia. Very, very important cause. Or probably you might result in a freshwater drowning, where freshwater is like no salt is there. So freshwater drowning may also result in water intoxication, but rare cause, not given in many textbooks. But we have encountered these conditions. So psychogenic polydipsia is a very, very important cause. intentional drinking of water. Even in the presence of normal solute intake, you might get water intoxication here. So that is why we split into urine osmolality less than 100 or more than 100. So this is a very interesting thing. So how to differentiate the causes and how to know about these causes, super, isn't it? So this is how you get a hypovolemic, euvolemic and hypervolemic hyponatremia. Suppose now let me tell you the treatment of hypovolemic hyponatremia. What is going to be the treatment of hypovolemic hyponatremia? Obviously, any hypovolemic patient, the best fluid of choice is isotonic normal saline or isotonic saline, 0.9% NaCl, because that can replace the volume rapidly and they can correct the sodium also. That's why it is very good. But one danger is there, that is rapid rise of sodium. Rapid rise of serum sodium is there, which means there is a risk of osmotic demyelination syndrome, which we have discussed previously. Very, very important point. Why these patients are having high risk? Because a hypovolemic patient will have accelerated ADH response. This accelerated ADH response means they are actually conserving more water relatively. Excessive water reabsorption. And that is the reason you result in hypovolemic hyponatremia. The equation tells total body sodium divided by total body water, where the total body sodium will be low, more compared to the total body water. This mismatch is happening. So why this mismatch? Because they're relatively conserving more water compared to that of the sodium because of the excessive ADH. That's why they're having, loss of water is little less compared to that of the loss of sodium. That's why your serum sodium is low and resulting in a hypovolemic hyponatremia. Now, what will happen when you are giving a isotonic saline? When you are giving isotonic saline, you are abolishing the hypovolemic response. You are making the patient to a normal volume status, which means you are abolishing the ADH response, and which means you are actually abolishing this water reabsorption mechanism, which means now the water will be lost in the urine compared to that of the sodium, because sodium is now getting conserved because you are giving sodium chloride, and now because you have lost the ADH response, now you are losing a lot of water in the urine also. So more sodium compared to loss of water in the urine will result in rapid rise of the serum sodium, resulting in increased risk of osmotic demyelination syndrome. That's why you have to be very, very careful. That is due to abolition of the ADH response when you correct the hypovolemia. Okay. But when you take this euvolemic or hypovolemic, hypervolemic hyponatremia, what could be the probable treatment? So you are having a euvolemic or a hypervolemic hyponatremia. In general, the most important treatment for euvolemic or hypervolemic hyponatremia is fluid restriction. Fluid restriction, because in euvolemic hyponatremia, the most important reason is the excess total body water. That's the problem. So whenever you have excess total body water, obviously you have to correct it by fluid restriction only. That's why in euvolemic or hypervolemic cases, which is causing dilutional hyponatremia, the most important treatment is fluid restriction. Apart from that, you can use a lot of treatment options. For example, if the patient is having low solute intake, you have to increase the solute intake. That itself is enough, and correct the malnutrition in this patient. That itself will improve the hyponatremia. Or if the patient is having psychogenic polydipsia, here the most important treatment will be water restriction and psychiatric counseling, like cognitive behavioral therapy. That's what we're going to use. Similarly, patients who are having SADH, already we have discussed the treatment options for SADH in detail. You obviously give fluid restriction. At the same time, you are also going to use other options like urea, salt tablets, furosemide, and even you can use Vaptans, and last but not the least, lithium and demiclocycline, which is not used nowadays anyway. So all this can be used as a therapeutic option in case of SADH. We have discussed already. Similarly, hypothyroidism, you are just going to replace levothyroxine. In adrenal insufficiency, I am just going to replace cortisol in the form of hydrocortisone. That's all. That's going to correct the disorder. That's why these causes, again, these patients who are having euvolemic hyponatremia, again there is a danger of rapid correction of sodium. Why? Because again these are easily correctable causes. SADH, easily correctable. Adrenal insufficiency, give cortisol, immediately it gets corrected. Hypothyroidism, thyroxine, immediate correction. Psychogenic polydipsia, water restriction, immediate correction, isn't it? And Beer potomania and T-dose syndrome give more solutes. Correction happens immediately and almost instantaneously. So this is something, like easy correction. So that's why. And similarly, in patients who are having hypervolemic hyponatremia, again you can add adjunctive therapies like Vaptans, loop diuretics like furosemide. So that is to lose water, because I told you loop diuretics lose a lot of water. So again, this is done to reduce the volume status of the body, to reduce the hypervolemia, at the same time to lose the total body water, so that the dilution effect will be lost and the serum sodium will improve. So, but the most important quintessential treatment for most of the case of euvolemic and hypervolemic hyponatremia is fluid restriction only. How hypervolemic hyponatremia can improve by fluid restriction? You know the equation in hypervolemic hyponatremia, that is total body sodium will be very high and total body water will be very, very high. So again, it's due to excessive water conservation causing dilutional effect. That's the reason. So obviously giving fluid restriction will definitely correct this excessive water load in the body, and they will make the serum sodium in the normal range. Apart from that, you can give loop diuretics to reduce this fluid overload by reducing the total body sodium. So loop diuretics are excellent natriuretics, isn't it? So they can reduce the volume status by causing natriuresis. At the same time, you can also use adjunctive Vaptans, I told you, that is to reduce the total body water more and more. So these are very, very important concepts again. So this is how I'm going to normalize the serum sodium in the presence of hypervolemic hyponatremia. Okay. So let us see the summary now. Summary wise, what are the steps you have to take whenever you want to approach a hyponatremia? So you have a serum sodium that is low. If they ask you what you do in step 1 is to see the serum osmolality. So now you classify into hypoosmolar, hyperosmolar, and normosmolar. Normosmolar and hyperosmolar, it's a different entity. It's a false hyponatremia. We discussed already in detail. So now come to hypoosmolar state. So now we are sure it's a hypoosmolar hyponatremia. That is low serum osmolality. So step 2, always rule out 2 conditions. That is thiazide-induced hyponatremia and renal failure related hyponatremia in the first place, because these two are really, really important, because straightforward causes don't no need to evaluate any further clinically. Once you have ruled out, then move to the step 3. These 2 causes are not there. Now you are going to assess the volume status in the body. So remember, volume status should be assessed clinically. Most of the times it's easy to find out a hypervolemia, but a little bit difficult difference between a hypo and euvolemic status. But anyway, so according to exam, see the volume status. Volume status can be hypo, eu, or hypervolemic. Hypovolemic hyponatremia will be obvious most of the time. So in this condition, next step is see the urine sodium, whether it is more than 40 or whether it is less than 40, less than 25. Less than 25 means it's usually diarrhea, lower GI cause. More than 40 means it could be renal salt wasting, like acute diuretic use, primary adrenal insufficiency, or it could be even a cerebral salt wasting syndrome. Alternatively, even vomiting can produce by a lot of mechanisms which we have discussed in detail. Euvolemic means urine sodium is not going to be useful. Urine osmolality will be useful if it's more than 100 or less than 100. More than 100 means I'm going to think about SADH and related conditions like hypothyroidism and secondary adrenal insufficiency, hypocortisolism. Less than 100 means it's due to excessive water ingestion. That might be due to low solute intake like Beer potomania and T-dose syndrome, or it could be psychogenic excessive water ingestion like psychogenic polydipsia. Hypervolemia means usually you are going to have a low EABV cause, low effective arterial blood volume, once you have ruled out the renal failure, which is due to low GFR. So low EABV means they are going to activate RAS, which means it's going to be a lot of sodium overload and excessive sodium reabsorption. That's going to be the cause of this hypervolemia. And here the causes will be 3. One is cirrhosis, CHF, and nephrotic syndrome. Very, very, very important causes. Nephrotic syndrome. Most important. These 3 causes. In this, I told you in CHF and cirrhosis, hyponatremia itself indicates a poor prognosis. In hypovolemic hyponatremia, isotonic normal saline 0.9% NS will be the best option, even though there is a risk of rapid correction of hyponatremia. the most important treatment options for euvolemic and hypervolemic hyponatremia is fluid restriction. In these patients, generally avoid 0.9% normal saline because there is no need to expand the volume, because already either in euvolemic cases total body sodium is normal, so there is no need for sodium excess or any volume, because they are euvolemic and you don't, I mean, isotonic saline is to give volume replacement, and you don't need, technically and theoretically as well as practically, you don't need a fluid that gives volume to the patient. And similarly, hypervolemic patients, again, there's no point in giving NS because already they are hypervolemic and they're having sodium overload. And why you want to give a fluid that gives more volume to the patient already if they are hypervolemic? So again, it's not logic. So don't use this fluid in euvolemic and hypervolemic patients. Clear? And one other condition I didn't tell you, which can mimic a euvolemic hyponatremia, which can produce a euvolemic hyponatremia, that is chronic diuretic use. I already told you chronic diuretic use will never produce hypovolemia. They will only produce a euvolemia. Acute overdose or intoxication of diuretics or ingestion of diuretics may result in a transient hypovolemic state, but chronic diuretic use always makes the patient euvolemic because of a lot of adaptive changes that are happening in the body. Remember, a chronic diuretic use may change the patient from a hypervolemic state to a euvolemic state, but usually they don't make the patient from a euvolemic state to a hypovolemic state. You have to be very careful about it because of a lot of adaptive mechanisms which I have discussed in the SADH chapter. So there are some conditions that can mimic a chronic diuretic use. For example, these are congenital conditions like Bartter syndrome and Gitelman syndrome. Bartter syndrome mimic a loop diuretic use and Gitelman syndrome mimic a thiazide diuretic use, and these patients also will have a euvolemic hyponatremia. The entire purpose of telling this is this only. Bartter syndrome and Gitelman syndrome patients will have euvolemic hyponatremia only. Clear? And similarly, diarrhea will have, renal salt wasting will have high urinary chloride, and this vomiting will have a low urinary chloride. Again, that's a very important point and multiple times asked question in your exams. So this is how you approach a hyponatremia in a nutshell. And with this, we can finish the approach to hyponatremia. And in the next section, we'll be discussing on the treatment aspects of hyponatremia, which is again very important. Stay tuned and keep watching.